Good afternoon, and thanks for the invitation. This is our preferred method of chondrogenesis, involving arthroscopic subchondral drilling followed by injections of peripheral blood stem cells to reverse the pathology. We named this procedure KART, and we are very privileged to introduce this method for the first time in this presentation. This is an article using KART to address massive knee chondral defects. A Level 1 study from our recently completed US FDA Phase 2b randomized controlled trial. We evaluated the safety and efficacy and concluded that KART showed significant clinical and radiological improvements. KART is able to address massive cartilage defects provided we adhere to its three main principles, namely specialized surgical technique, multiple injections, and tailored weight-bearing physiotherapy. In the early days, we drilled too far apart. Second look arthroscopy showed individual tufts of cartilage. This gave us an idea that if every drill hole created a tuft of cartilage, we can theoretically drill the whole joint. So we drilled closer and deeper. This initially showed a cobblestone appearance and progresses to a thick layer of cartilage covering the entire area. We developed an arthroscopic drill with a pointed tip, designed to drill with a diameter of 2 mm to a depth of 6 mm, leaving 1 mm gaps between the drill holes. This patient had tricompartmental chondral defects. This is following lateral patellar release and drilling into the massive patella and trochlear chondral defects. Chondrogenesis as shown at 2 years. The same patient with chondral defects of the medial femoral condyle and bone-on-bone lesions of the lateral compartment. Cartilage regeneration as shown at 2 years. These are my standard arthroscopic portals. An accessory high medial portal is placed for drilling of the medial tibial plateau with the knee in flexion. Drilling is made via this portal without the use of tourniquet. This is following drilling to the medial tibial plateau. When performing lateral patellar release, the arthroscope is switched to the medial portal and the vaporizer is from the lateral portal. This is the standard lateral portal, and the arthroscope is now viewing from the previously placed superior lateral portal. I have placed an additional inferior portal at the mid-patellar level. This allows for drilling to the lateral patellar facet by pushing the patella laterally and tilting it with my left hand. Drilling is via this inferior lateral portal. Once the patella is tilted laterally, this area can then be drilled easily. This is the view after drilling the lateral and central patellar facets. We harvest stem cells from the blood. The cells are then kept in vials and cryopreserved in liquid nitrogen. This is another article from our group showing that peripheral blood stem cells are pluripotent. Our previous animal and human studies with cartilage biopsies showed that collagen type 2 is only present in the groups with stem cells. We published results of combining HTO and chondrogenesis. This showed the ability of KART to address bone-on-bone massive cartilage defects of the medial compartment. We reported results of cartilage biopsies and showed that the regenerated cartilage approached 95% of normal cartilage scores histologically. This is only evident when we injected once per week for the first 5 weeks after surgery, followed by once per week for 3 weeks at 6, 12, and 18 months after surgery. We drill into the cartilage defects, harvest blood stem cells, and inject into the knee. This allows for bone and cartilage regeneration by first building bone and then the calcified cartilage layer and eventually the articular cartilage. We have shown that biopsies from the weight-bearing medial compartment reveal an abundance of collagen type 2. This is in contrast to the intercondylar non-weight-bearing area. Biopsy from this area showed lesser collagen type 2 and more collagen type 1, and the collagen fibrils are not aligning along the axis of weight transmission. Therefore, weight bearing is essential for chondrogenesis. After surgery, CPM is used on the operated knee 2 hours per day for 1 month. Patients with drilling to the femorotibial joint are instructed to partial weight bear 15 to 20 kgs from post-op day 1, progressing to full weight bearing in 6 to 8 weeks. There is a difference between weight bearing for the femorotibial joint as opposed to the patellofemoral joint. For the PFJ, when the knee is in full extension, there is no loading across the patella and trochlear components. Knee flexion is needed to provide loading across the patella and trochlear components. We start with static loading in the sitting position with a variable degree of knee flexion. This is to allow loading across the PFJ. At 2 weeks, we commence standing step presses initially at 30 degrees, then at 60 degrees, and at 90 degrees with progressive weight bearing. Cycling starts at 6 weeks with a variable angle to allow PFJ loading. Initially no resistance, otherwise the drilled surface of the PFJ will grate off the normal cartilage like a cheese grater. Static shift squats is performed at variable knee bending angles to load the PFJ. This then progresses to dynamic knee loading across the PFJ. This is a comparison between KART and microfracture. The crucial difference is that KART regenerates hyaline cartilage as opposed to fibrocartilage. So, what are our limitations? Are we able to drill the whole joint? This patient had end-stage ankle OA. I drilled the whole ankle joint. MRI at 2 years showed chondrogenesis and reappearance of the ankle joint space. KART also has the ability to address massive osteochondral lesions. This international patient had previous OATS. Knee arthroscopy showed loose OATS cylinders. These were removed and the defects were drilled. Post-op MRI showing the drilled osteochondral defects. MRI at 2 years showed healing of the osteochondral lesions. This is the QR code that you can download for all the published manuscripts. Please visit our website at klsmc.com. We're hoping to commence our FDA Phase 3 clinical trial when the pandemic is over. Any of the audience interested to be involved with our clinical trial or to learn more, please get in touch. Thank you.